Welcome to Designing Healthcare That Cares, the show where we explore how to build healthcare systems where people and performance thrive. I'm your host, Dr. Laura Suttin, a physician, coach, and healthcare leader who believes that human flourishing and organizational excellence go hand in hand. Each week, I talk with leaders, change makers, and innovators about how to shift culture, lead with purpose, and tackle the root causes of burnout. Because when healthcare works for the people in it, everyone wins. Welcome to the Designing Healthcare That Cares podcast. I'm so excited to have our guest today. I'm going to introduce Amy Shaw to you guys. So Amy Shaw is a dementia clinician, an educator, and founder of Better Dementia, a trademarked national platform that's dedicated to helping families care for loved ones with clarity, confidence, and compassion. Amy is the author of The Arc of Conversation, a how-to guide for goals of care conversations, a medical textbook used by clinicians and educators, and she's currently writing a book for family caregivers to be published next year. As an undergrad at Emory University, she studied primate cognition, brain development, and language acquisition, traveling to Uganda to study chimpanzees. And her work in dementia care feels like a full circle return to those early questions about how brains develop, change, and make meaning. Amy, welcome to the show.
Thank you so much. I'm so honored to join you in this conversation.
Yeah, really good to have you. It's a very interesting topic, and imagine a lot of our listeners are going to connect with this. And so really want to hear what's mentioned in your bio, your undergraduate work, and I'd love to hear if you can share with our audience how you got into this work and why this is so important to you.
Yeah, I mentioned that it really feels like a full circle moment. I've always been interested in human behavior and cognition, how we think, this incredible organ of the human brain, how it arrived to be this incredible instrument to allow us to navigate our world. And so I studied that as an undergrad. I participated in research throughout my undergrad experience. That was amazing. But I quickly realized that I'm too much of a people person to want to be isolated in a lab. And so decided that I actually didn't want to do research as a career after undergrad with a degree in psychobiology, primate cognition, human development. Until I progressed through my education, I couldn't really get a job with that. So I became a wedding photographer. And I always say right now that the best preparation for what I do right now, which is to help families through a really challenging experience of a medical journey, the best preparation for that was being a wedding photographer, because it's a very similar moment in a family's life. A lot of different expectations, financial constraints, decisions, planning, etc. And my role as a photographer to be there with the family on that day was very similar to what I do now, to help people navigate through a very challenging, emotionally charged experience in a way that preserves everyone's well-being and dignity, right? And helping navigate family dynamics was a big part of my job as a wedding photographer. And so that work really prepared me when I decided I needed a career that would withstand the next recession. I was part of the hospice team. And in the small community hospital where I worked, the palliative team is only PAs and NPs. And there was very little training or onboarding. And I essentially had to teach myself. And there are lots of textbooks out there in the world that teach how to manage symptoms in the palliative world, how to manage constipation, pain, nausea, etc. There was no textbook to teach me what was I doing in palliative care. What was my job in conversation with family? And I quickly realized that, wow, after spending 3 years in cardiology, and I probably worked with 2 or more dozen cardiologists because our local community hospital depends a lot on locums providers that come in from the rest of the country. And I never once heard a single cardiologist use the phrase hospice criteria in a way that allows patients and families to investigate their values, articulate their wishes, and so then we can work to align their wishes with their medical care. I hadn't heard that phrase until I moved into hospice care. And the problem with that is that Heart disease is the number one cause of death for humans on the planet. It is the leading cause of hospitalizations for many hospital systems. And to realize that I had only training in diagnosis, that is recognition of disease, treatment, and potentially cure of illness. I had no training, no framework to understand disease as a progressive journey that impacts not just the patient, but the family at home, right? And that's the connection with wedding photography. Chronic disease and terminal illness is a full family affair. It is multi-generational. It impacts people at home where the living happens, right? When a person's in the hospital, they're worried about who's feeding their dog at home. And we highlight in medicine this pillar of medical ethics called patient autonomy, which means we respect patient choice. But what I realized is that people don't know where they are in a healthcare journey. And therefore, if you don't have an accurate framework for understanding where you are and what is likely to happen next, it's practically impossible for you to make decisions and choices that are well informed. A good example of that is asking somebody, if your heart stops, do you want us to restart it? Right? That question really misses the complexity of a human life. Restarting somebody's heart with cardiopulmonary resuscitation is not like unplugging and plugging in your computer again, right? The effectiveness of that depends on your age, your health conditions, et cetera. And so I quickly realized that we, the medical system, and it's not our fault. I'm not pointing a finger at individual providers. It's a fault in the system. I looked backstream and realized, yikes, I didn't get any training in end-of-life recognition, in care, in conversation. And that is the same in med school, NP school, PA school, everywhere.
Yeah.
And so how would we recognize something if we're not taught to recognize it? And so I pulled together all these resources and then wrote the textbook that I needed to have a clinical framework for recognizing the end of life, for how to evaluate where a person is, how to create a compassionate, collaborative space for conversation with patients and families. And then the approach that I teach in my textbook, The Arc of Conversation, a how-to guide for goals of care conversations, the goal and purpose of that is to teach this approach to conversations that allows a provider, a physician, a clinician of any kind, to investigate a patient and family's experience, their pain points, their confusion, ask them what do they understand about what they've been experiencing, to help them fill in the gaps with education about disease. It provides education for the clinicians first to understand the terminal trajectories, to understand how to evaluate where a person is, and then the stepwise movement through a conversation that I have found to be very, very effective in moving people that maybe don't even know that their loved one has dementia, right? They think they're in the hospital for pneumonia, but that's actually end-stage dementia. And to move a family caregiver from a point of not having a diagnosis, not understanding where they are, to filling in the gaps, providing amazingly informative and comprehensive education about disease, pointing out the experiences that they've had so that they, in their own mind, can put the puzzle pieces together and arrive at a place where they understand and recognize where they are in their journey authentically from within their own experience. Then to provide space and time for an investigation of their values and wishes so that they can articulate what they want in whatever time they or their loved one has. Absolutely, that is patient autonomy when we get a person there, and then to work from there to align their medical care with their wishes. When I precepted medical doctors in their residency, one of the first things that I would teach them is that it is the easiest thing in medicine to give people exactly what they want at the end of life.
Yeah.
If we only make the time and space to ask them and to help them understand where they actually are in the journey, every single person, I've probably asked more than 2,000 people what they want at the point in their life when their time is limited. Every single person has told me that they want to pass away in their sleep.
Yeah.
The way to help that happen for a patient and for a family is to give them time and space to process where they are in their disease journey, to educate them fully about hospice, its purpose, and to give them the space and time to arrive in their own time. That decision is what is best for them. This is one of the important lessons that I took from my work as a wedding photographer, was this approach to sales, if we want to call it that, in a way that is pressure-free, that does not push things on people. And that is sadly often what happens in medicine. We are taught to diagnose, treat, and fix. And then when we don't have any other options, we say, there's nothing else I can offer you. It's time for hospice.
Yeah.
The patient and family then feels like the medical system has given up on them.
Mm-hmm.
And if we do this approach to a conversation, and this is how I build my model of medicine now that I practice privately with patients and families, if we start in a place where we provide space for these conversations and education and the information about hospice, because as I write in my book, death is not the surprise ending of a human life. Everybody's going to pass, and everybody has wishes for that point in their journey. Then we can set them up for investigating what they want and articulating their wishes outside of a crisis.
Yeah.
It's really effective, and families really appreciate it. It actually reduces a lot of the fear and stress that they anticipate along the way.
Yeah. Thanks for sharing all that. I love the journey from wedding photographer to dementia clinician is beautiful. It makes perfect sense. And now that you say it, though, you're witnessing this momentous occasion in somebody's life, and there's so much stress and so much going on. And yeah, that's a great analogy. And you can make suggestions based on your experience about, well, I think this will work, or this might not work, or yeah, it's a very delicate position to be in. Having been married twice myself, I think about my own experiences there. And what you shared about, going back to what you said, I can only speak, of course, from my experience, and then also what I've seen in Western society about how we talk about death, how we talk about end of life care, or don't talk about death and don't talk about end of life care. I know that other cultures are more open to speaking about it and planning for it and having conversations with their families about it. But it's something that, again, in my experience, has largely been taboo. And in my clinical practice, when I was with a large health system, most of my patients were over 75. And so I found myself in this situation quite a bit. I was lucky to work with some amazing colleagues who were trained in geriatrics and palliative care, who provided a ton of education for us on how to have these conversations, how to start these conversations, not even at the time of a terminal diagnosis, but on a very first visit with a patient, making it part of the annual wellness visit for Medicare billing or yearly physical. Let's have these conversations. Let's make sure that I know what your wishes are, so that in the event that you can't speak for yourself, I know what your wishes are, your family knows what your wishes are, and normalizing it and removing that stigma, removing the taboo, because like you said, we are all going to be at the end of our life at some point, and we all have wishes about what that looks like. Unless we speak those, we can't assume. And in my experience, patients found the word hospice to be like, I'm giving up on you, kind of like you said, there's nothing else I can do for you, or hospice means I'm about to die, or hospice is where people go to die, and it means they're not going to do anything for me. And then when patients would learn, actually, you can receive pain medication on hospice, you can receive antibiotics, you can receive IV fluids if you want. You may be able to still get dialyzed. There are limits and those change, but we're still going to take care of you on hospice. And here's what hospice means. Here's how to approach it and how to think about it. I love that mission, and I love your education for other clinicians, and now moving into, well, you've been educating families, but now creating a book for it and creating some online education. It's so needed.
It really is. The dementia journey I found in particular is at the intersection of human behavior, our medical systems business model, and what you just touched on, our sort of failure, let's call it what it is, to prioritize conversations like this. And it's not the clinician's fault. Our business model of medicine is built on seeing as many people in a short amount of time as possible. And the most important value in the equation of the medicine practice that I do is time. Patients and families need time to process, to understand, to receive education, to go home, to sleep. The way our brain learns things is through consolidating what we've learned and heard during the day into new networks overnight. And so to have even an understanding or an expectation that we could accomplish all of this in one conversation is erroneous, right?
Yeah.
And so part of what I do in structuring my private practice, I offer to families across the country this sort of concierge service to help them navigate this dementia journey. I teach them the what, when, and why of dementia. It's clinically grounded in everything I understand about brain development, cognition, neural networks, et cetera, so that they can master the how of caregiving. I teach them practical strategies that align with the realities of what is breaking in the brain.
Yeah.
And so right up front, when I meet with families, I have 3 visits with them to start, and that's often done within the first couple of weeks or a month. And I highlight the high-level education about the entire dementia journey. So exactly what you mentioned before, at the start of working together, I prepare them with the entire roadmap of what they will be facing, because many families are worried about what happens in the future. And when they have this framework, when they have this roadmap, and they have specific communication and support strategies that I teach that align with each milestone of cognitive loss, they have practical tools from the first visit. I can see their stress come down.
Yeah.
They say to me during the second and third visits, things are better at home. And I get to tell them, congratulations, that's because you have done an amazing job of integrating what I've taught you. And it's coming from compassion. It's coming from you authentically understanding what is happening now. And that really transforms this journey for people who are caring for a loved one with dementia. And I structure my practice, even in Wyoming, where I can practice medicine, right? Where I can diagnose and I can manage psychiatric symptoms of patients with dementia. I still structure my practice in a way that suits this journey. This specific disease trajectory is built specifically to be missed by our medical model.
Yeah.
Right? Our medical model is built on the patient and clinician relationship. And it assumes that the patient has intact cognition and can serve as a reliable historian about their own experiences, symptoms, etc. And for reasons that I teach extensively, dementia, by definition, disrupts that capability from the start.
Yeah.
This is a big part of why this journey gets missed, right, for many, many years. And so my education, especially if a family is worried about a loved one at home, prior to a diagnosis, in my next book that I have coming out, I have a chapter called Pattern Before Pathology. Diagnosis begins at home. Recognizing and validating the reality of dementia is that family members see the changes typically before it shows up in a 15 or 30-minute clinic visit. And so having this educational framework and support from early on helps preserve relationships, well-being of the caregiver, and dignity in the person with dementia. This is why I chose the name for my business, Better Dementia. This journey does not have to be all doom and gloom. If caregivers are supported with comprehensive education from the start, they can navigate this journey with grace and with a lot more confidence and a lot less guilt.
Yeah. Just to piggyback on what you said about how by and large, our medical system is not built to manage or allow time for these conversations. I know there's been some changes with Medicare about can bill for these conversations and that type of thing now. Still, the prevailing fee-for-service RVU-based model in this country, where patients have to be seen every 15 to 20 minutes, just doesn't allow for these times. I was fortunate enough, I was practicing in a value-based care environment that allowed for longer times with patients and really allowed for these types of conversations in a different type of way. And I still missed dementia more than I am like to admit in my patients, because they would come in by themselves. Maybe they were driving, but maybe they took the bus or the transportation we provided for them. And I just didn't see that side of them. I didn't see that they had been leaving the stove on or they've been falling. And depending on the type of dementia they had, they might lie and I wouldn't know it. So the family is such a big part of this conversation. I'm just grateful that you bring them in from the front, and the tools that you're providing them are really lessening that stress, giving them what to expect when your family member has dementia, and that they can understand this is the disease progression. You're not doing anything wrong. This is what's natural. These are some things that you can do. Something simple like things that I've had to tell my family members of patients with dementia, like, don't argue with them. They really believe X, Y, or Z. So just as best you can go along and play along, that type of thing. Understand about sundowning and all of these things that are a surprise and can shake up somebody's daily routine in their life and cause a lot of upheaval. So thinking about the name of this podcast, Designing Healthcare That Cares, bringing in these conversations and treating patients with dementia with dignity and treating their family members with that dignity, that's a huge part of it.
Absolutely. One of the frustrations that I had with the traditional model of medicine is that it requires the patient to be present for visits.
Yeah.
And really support caregivers to provide education that really is grounded in the clinical reality of dementia and what is breaking in a person's brain. I have to be able to speak quite frankly with the family in order to evaluate and assess and help them understand where their loved one is in their journey. I need to hear from all of the family members, frank, detailed conversation about what is happening at home.
Right.
That cannot be done with the patient in the room if we are to uphold their dignity.
Yeah.
And when I worked at the hospital system, very quickly I realized the palliative care system itself also wasn't supporting people with dementia appropriately. For this reason, I read an article about a program that UCLA had developed, reached out to them, and we became one of the first 15 dissemination sites in the country to offer this comprehensive dementia care program. And I was the sole provider for, I think, almost 4 years. I helped over 450 families with a loved one with dementia. And I put my own approach that I teach in this book onto that comprehensive care model. And I realized very quickly that this doesn't work for people who are early enough in their dementia journey who can still understand this conversation. It is very traumatizing to them. And so I really fought for an approach where I could meet with families separately. There was no billing model for that.
Yeah.
And now in my private practice, I meet with families separately from the patient. When I visit with the patient, it's to really assess if what they believe to be true is comforting or not comforting to them. If they are suffering because of what they believe, then I manage that either medically or through communication or support strategies. But my work with families is separate. I meet with families online, Google Meet, etc. And we can have now frank, full, comprehensive conversations. And dementia is not static, right? It's a journey. And I teach families, everyone's brain is the only brain that's ever existed in the history of humanity in that precise configuration. So everyone with dementia, even 100 people with Alzheimer's disease, are going to showcase a different trajectory, right? Because the information in their brain is unique. And even though there are patterns and expected milestones of loss that I teach in a way that makes it very easy for families to recognize at home, when I'm providing my framework, my staging framework, families say, oh, we're here. That's where we are in this journey. When I teach them strategies, I can see them working through, oh, I didn't do that right before. And I always reassure them, it's okay. You didn't have a roadmap. How would you be expected to navigate this wilderness without a map and a compass? So we're starting from here on out, right? And you're going to integrate what you've learned that did or didn't work. And you're going to now have very effective strategies that align with what is breaking in a person's brain. We know there are different neural networks that are responsible for different cognitive functions. And I teach caregivers how to be a cognitive detective and work back from the evidence that they see, because people with dementia, like you said, don't in the clinic come in waving their memory and cognitive incompetence flag.
Right.
They don't. There are actually specific reasons that the brain does not have. Our brain is not like the shuttle, with all these control and test systems. It doesn't have that.
Yeah.
So people don't have insight. And what you mentioned that, families or practitioners often think a person is not telling the truth, that actually weighs on caregivers in what I call the heavy caregiver backpack. It's full of these heavy emotional bricks. We humans are sense makers. We want to live in the why. And in the absence of accurate understanding, we make it up. So caregivers who don't understand why a loved one is not telling the truth say they're lying to me.
Yeah.
They're manipulating me. In a family system is a hard brick to have in your backpack. That makes a lot of suffering. And then human behavior comes out of our beliefs about how a person is treating us. And so then I often work with families where there's a lot of conflict at home because of this dichotomy, right? They don't understand the reality of what is happening. And this is causing just unmitigated suffering at home. Yeah. I've seen lawsuits and divorce. We haven't even talked about the fraud and abuse that people with dementia are at risk of, but all manner of difficulty at home that could be avoided with education.
Yeah. Yeah. Like you said, the conflicts and tension that I've seen, if there's already a strained relationship between parent and child, even though the child is now 50 or 55 years old and caring for their 80 or 85-year-old parent, it's a tinderbox sometimes.
Yeah. And it doesn't have to be that way. I am so grateful that I get to live and work in my purpose and help people every day. I'm just honored to get to help a family. Whenever I get to do that, it's really amazing, incredible work. And I'm just truly grateful.
I'm grateful for it too. And I thank you for being on and sharing with us. Where can our listeners find you?
Thank you so much for having me. This has really been an honor and a pleasure. Listeners can find me online at betterdementia.com. I'm on all the socials now, so they can follow me on their favorite social media outlet. And I want to tell families anywhere a couple things. One, I can work with families anywhere in the country. If you have an internet connection, we can connect and I can help you through this journey. Two, I want to say that, and I tell this to every family that I meet, your loved one is doing as well as they are because of you. The work that you are doing to help support and care, even in the moments when it's challenging and you think that you're not doing it right, your loved one is really, really fortunate to have you. And third, for people who would like to do some self-paced education, I just recently recorded a video version of my education framework that I teach to every family that I work with privately. And that's available also on my website at betterdementia.com. This course is comprehensive and it teaches specific strategies for communication and support that align with each stage. It teaches how to understand the different levels of care facility that families often face that decision, how to effectively move through a transition, either bringing some help into the home or actually moving a loved one to a care facility. That's one of the most challenging decision points that caregivers face. The final stage of the dementia journey comes with a lot of different medical realities. And so I do a very in-depth educational approach to helping caregivers understand the medical realities that they will be faced with towards the end of life. And I actually guide them through the same questions that I guide families that I work with privately, so they can investigate their own values and come up with their own wishes, goals, and understand how to align those goals with the medical care that they will be forced to make decisions about. And it also comes with a complete primer on hospice. So families really understand everything with this education course, and it's self-paced. No lesson part is longer than 20 minutes, so it can fit into busy caregiver schedules, and it builds on itself. It's really a journey, and it's a place that caregivers can come back to over and over again. So I'm really excited to make that available to a larger audience and to help transform the lives of more families on this journey.
Sounds like a phenomenal resource. And thank you for what you're doing. Thank you so much for being on.
Thank you so much for having me. This was a real honor and pleasure.
Thanks for listening to Designing Healthcare That Cares. If today's conversation gave you a new idea or inspired you to see things differently, share this episode with a colleague and keep the conversation going. And if you're ready to take the next step in building a thriving healthcare culture, you can find resources and ways to connect with me at drlaurasuttin.com. This podcast is for educational and informational purposes only. It is not medical advice, and it should not replace care from a qualified healthcare provider. Always seek the guidance of your physician or other qualified professional for any medical questions or decisions.